Our session is going to be a continuation of the basics of ECG. So I think it's some time we had done the initial two classes on ECG, and now today is the third and the last class on the basics of ECG, which will include the electrical axis. Now the electrical axis is decided for the Qrs complex, the P wave and the T wave also. Commonly in practice, we calculate the Qrs axis and the P wave axis. The principles for all the three axis calculation is the same. Also going back to the...
Excuse me, ma'am.
Yes, Amrita.
Ma'am, we can't hear. Can you please come close to the mic?
Is it faint or not at all?
It's a faint voice.
Now can you hear, Amrita?
Everyone, please, can you hear?
Is it audible?
Yes, ma'am. Now it's audible.
Now it's better? Okay.
Yeah.
Okay. So we will, just summarize what I spoke so far. That today's our session is going to be on electrical axis. The axis calculation is done for commonly the Qrs complex and the P wave, and also sometimes the T wave. As you all know, the T wave and the ST segment have something to do with repolarization. The P wave has something to do with the atrial depolarization, and the QRS with the ventricular depolarization. Now, before we start understanding the axis calculation, we also need to know that every age has a different normal axis because the ventricular dominance is different. So when the baby is born, the RV is the dominant ventricle. To that extent that if we calculate the LV-RV ratio of its weight, then it comes to 0.8:1, which slowly becomes 1:1 in few weeks, and by 6 months it is 2:1. That means LV becomes much more dominant than the RV, and then in adults it continues the same way, where LV-RV weight ratio stays as 2.5:1. So as we understand, RV is the dominant one during pregnancy and at birth, and LV is the dominant one in adults. This shift from RV to LV dominance happens very gradually from birth to adulthood. And hence, the QRS axis also changes from right anterior in a newborn to left posterior in an adult. Now I'll go back to that understanding of the two systems which we had understood. One is the horizontal system and second is the axial system. The horizontal plane or the axial plane tells you an understanding about the entero-posterior and right-left direction, whereas a sagittal plane gives you an understanding about the right-left but more superior and inferior aspect. Now there is an age in between where you can have a transition zone which stands between 1 month and 3 years of age, where ECG can be indeterminate. So now we will start with an understanding of the QRS axis. As you know, the QRS is an understanding of the ventricular depolarization. The activation of the ventricles happen in a synchronous way, and you have multiple vectors which are happening simultaneously. So as you can see here, there are multiple vectors which are happening simultaneously in the ventricles. The dominant vector initially starts in the interventricular septum, which is more left to right. And then there is a small vector which is from right to left. But the final concluding vector in the IVS is left to right. And then you have simultaneous synchronous activation which is happening from the endocardium to the epicardium. However, at the end of it, we have to understand that the most dominant vector is from right to left, and hence you have an initial vector from left to right and then the final vector from right to left. What decides the QRS axis is the mean or the dominant direction of all the vectors. And this mean QRS axis is graphed on the basis of the 6 frontal plane leads. Now, if we can go back to the frontal plane leads, you would remember that in the frontal plane, this is the sagittal cut. We have 6 leads. This is lead 1 at 0 degrees, lead 2 is at plus 60 degrees, and lead 3 is at 120 degrees. These are the standard leads in the frontal plane. And then we have 3 augmented leads. The AVR at minus 150 degrees. This is the right upper limb. The AVL, which is at minus 30 degrees, which is the left upper limb. And then you have AVF, which is 90 degrees, which is in the right foot. So we have the 3 augmented leads and the 3 standard leads. And this total of 6 leads in the frontal hex axial system helps us to calculate the QRS axis in the frontal plane or the sagittal plane. And so you can understand here the understanding is more superior, inferior, right and left. Remember that these degrees which we are showing in the axial system have nothing to do with the first class which we did on positive and negative poles of the leads. But these degrees are important for us to decide about the axis of QRS, P and T. So the axis is decided in this plus till 180 degrees and in this way 0 to minus 180 degrees. The important landmarks would be 0 degrees, plus 60, plus 90, plus 120, minus 150 and minus 30 degrees. So most of the leads are between minus 30 to plus 120 degrees. So with this understanding, let us see. So remember you have the lead 1 here, which is leftward horizontal direction. So when you have lead 1 here, this half is going to be the positive for lead 1 and this half semicircle is going to be the negative for lead 1. So this is the positive and this is the negative segment of lead 1. Similarly, if you take lead AVF. So as you know, lead AVF is here plus 90 degrees and it's directed downwards in a vertical direction. So the semicircle lower half is going to be the positivity for lead AVF and the upper half is going to be the negativity for lead AVF. And like that, if you take lead 2, which is at plus 60 degrees, this half is going to be the positive polarity of lead 2 and this half is going to be the negative polarity for lead 2. You can take any lead and decide what is positive, what is negative, and based on that decide the QRS axis. So you can see here, this is again a revision of whatever we saw so far. And if you divide this graph into 4 halves, then you can see here that in this square, you have the lead 1 which is positive and lead AVF, which is also positive. For lead 1, this is going to be negative, and for lead AVF, this is going to be negative. If you take this part, then you can understand that AVF is positive and lead 1 is negative. If you take this part, lead AVF and lead 1, both are negative. And if you take here, lead 1 is positive and lead AVF is negative. So if you just end up looking at lead 1 and lead AVF Qrs complex and decide whether is it positive or negative, you can roughly get which quadrant the Qrs axis is belonging before you fine-tune it to the closest degree. And this is possible because you have two leads perpendicular to each other, 1 and AVF. Now, if you see similarly, lead 2 and AVL are also perpendicular to each other, and lead 3 and AVR are also perpendicular to each other. So you can take a pair of two leads which are perpendicular to each other to decide the quadrant in which the Qrs axis is lying. I hope this is clear so far. After this, we are going to go a little bit into minute details calculation. Remember that the net amplitude of the Qrs axis is obtained by subtracting the negative deflection from the positive deflection. If I have my Qrs complex as plus 10 and also minus 3, then the net amplitude is going to be plus 7. We will take an example in the coming slides. And also this gives us an understanding that the vector is parallel to a lead. That means you have a maximum positive upright deflection when it's parallel to a lead. If a Qrs complex is 0 degrees, then you will see the maximum vector in lead 1. And similarly, a vector is going to be perpendicular to a lead, then it's going to have equiphasic deflection. If I have Qrs which is equally positive and negative in lead 1, then it's going to be perpendicular to lead 1. So also it helps once you decide the quadrant, if you try understanding which lead it has the maximum positive upright deflection, then the axis is going to be across that lead. And also if you see an equiphasic deflection in any of the leads, then the Qrs axis is perpendicular to that lead. So these are the 3 points which can help you to roughly come to a Qrs axis determination. Now let's see here. You can see that this is lead 1 and this is AVF. And this area is going to be 1 and AVF both positive. Then you can come to this quadrant. Now, for example, you have a Qrs which in lead 1 is partly positive and partly negative. For example, it is 10 positive and 3 negative. So the net amplitude is 7 in lead 1. And hence you mark it as 1, 2, 3, 4, 5, 6 and 7. And you draw a line like this, which is perpendicular to lead 1. Now you try to find out the amplitude in AVF. For example, in lead AVF, it is positive 8 and negative 2. Hence, the net amplitude is going to be 6. So you draw a line after the 6 small squares like this. Now, the point where these two lines are intersecting is going to be the axis of QRS. I can repeat this once again. This understanding is important for all of you. Remember, first, what did we do? We found that it is positive dominantly in lead 1 and it's positive dominantly in lead AVF. So we decide that my axis is going to be in the left lower quadrant. Then to exactly find out the axis, I again go to see the Qrs complex in lead 1, where I see that there is some positivity and some negativity. So I will just do some math calculation. I subtract the negative from the positive and get a net vector, which is 7. And hence I put a point here and draw a line perpendicular from that point. Then I go to lead AVF and I find out the Qrs voltages. Again, it is more positive than negative, but I still need to subtract the negative from positive. And then it comes to 6. So I put a point after the 6 square and draw a line perpendicular. I will find a point where these two lines are intersecting. Then I draw a line from the midpoint to this intersecting point. So my axis is going to be here. That means my axis is somewhere lesser than 60 degrees, but more than 30 degrees. So it's somewhere around 40 degrees. So my Qrs axis is 40 degrees for this child. With this understanding, now I will go here to give you some clues. As we understood, if my vector of Qrs is parallel to, for example, lead AVF, then I'm going to get a deflection like this. My Qrs maximum positive in AVF, then my Qrs axis is 90 degrees. If my Qrs is maximum negative in lead AVF, then I'm going to get minus 90 degrees. So plus 90 or minus 90. My Qrs axis is maximum deflection in AVF. Coming down to the next understanding. If my Qrs is like this in AVF, either a little more positive but there is a negative component, or a little more negative but there is a positive component, then my Qrs axis is going to be like this. It's going to be slanting. Amrita, can you mute the center? I'm getting sounds from the SAT hospital. And last understanding is, if I have a small equiphasic null deflection, Amrita, can you mute the other center? There is a lot of disturbance coming, please. Or if we have a small equiphasic null deflection, that means I have a small positive, small negative, but the final deflection is going to be 0. That means my axis is going to be perpendicular to the AVF. So I hope this understanding is clear. Now with this, we are just going to run through once again, summarize how to decide the Qrs axis. So first of all, we need to try locating the quadrant. If my Qrs axis is going to be in left lower quadrant, my lead 1 and lead AVF both will show positive net deflection. If my Qrs axis is located in the left upper quadrant, both my lead 1 and AVF are going to be positive and negative respectively. If my QRS axis is in the right lower quadrant, my lead 1 will be negative but AVF will be positive. And if I have it in the right upper quadrant, then my both lead 1 and AVF are going to be negative. So once you look at 1 and AVF and see the dominant vector, you decide your quadrant. Once you narrow down the quadrant using lead 1 and AVF, after that try to find the lead which has equiphasic QRS complex. That means if I subtract the negative from the positive deflection, I'll be 0 or close to 0. That is called a null deflection or equiphasic QRS deflection. Then your QRS is going to be perpendicular to that lead with equiphasic QRS. And you need to stick to that predetermined quadrant. Why I am insisting on sticking? Because, see, for example, you are here, 0 to 90 degrees, which is left lower quadrant, and my lead AVL is showing equiphasic complex. That means I am perpendicular to AVL, where I can be plus 60 also and minus 120 also. But I've already decided that I'm in left lower quadrant, so I'm going to stick to plus 60 degrees. So once you decide the lead where you have equiphasic QRS complex, then you can go to see where you have the greatest QRS deflection in the predetermined quadrant. So I will have probably in lead 2 the maximum QRS deflection. So then my QRS axis is close to that limb. Whether it is positive or negative, again I will decide based on the predetermined quadrant. So these are the 3 basic steps to decide even before you fine tune. Remember, fine tuning to coming down to exactly 45 or 40 degrees may not be needed in many patients. So this is a quicker way to decide QRS axis. Now, also remember that sometimes you might have QRS complexes equiphasic in many limb leads. Then it gets a little confusing, and then there is a concept of calculating the initial vector versus terminal vector and then deciding 2 separate QRS complexes, and we are not going to go into the detail for confusion avoidance. Now, what is a normal QRS axis? At birth, as we understood, you have the axis which is more rightward. So any axis which is between 90 degrees to 140 degrees is considered normal for a newborn. And in an adult, it's between 0 to 90 degrees. And in between 3 months to 12 years of age, you can have it somewhere in between 90 to 120 degrees. So remember, an axis up to 140 degrees is normal for a newborn, but for an adult, it's usually not going to exceed 90 degrees. As you can see here, the normal QRS axis quadrant is the left lower. The right lower is considered to be right axis deviation for an adult. The left upper is considered to be left axis deviation, where 0 to minus 30 is light and minus 30 to minus 90 degrees is marked left axis deviation, and the right upper quadrant is considered to be the north-west axis. So this is the north-west axis. Generally for an adult, these 3 quadrants are considered to be abnormal. Now, when do you have left axis deviation? Sometimes you can have it associated with left ventricular hypertrophy or bundle branch block, and sometimes you can have it with pre-excitation syndromes where you have accessory pathway. The right axis deviation again can happen with right ventricular hypertrophy and right bundle branch block and also accessory pathways in different directions. Commonly, you will see it in congenital heart diseases like DORVs, tetralogies, where you have right axis deviation. Now, with this understanding, the message should go that a normal adult axis ranges between 40 to 60 degrees, though till 90 degrees it can be normal. Now, with this understanding of Qrs complex, we will go to the P wave axis determination. Remember, the principles are exactly similar and nothing to get confused. The difference is that P wave axis decides the direction of atrial depolarization. And all of you understand that atrial depolarization starts from the sinus node, which is the pacemaker of the heart. But in abnormal situations, the pacemaker could shift somewhere else also. And hence, P wave axis gives us an idea about the pacemaker. If you have the electrical focus which is originating from the lower part of the atrium, and then the atria is getting depolarized in a superior direction, then your Qrs axis is also going to be abnormally directed superiorly. The normal P wave axis, because we understand that from the sinus node it goes down and then it goes right and left. But the mean P wave axis is downwards and leftwards, which is plus 40 to 60 degrees, and it is also anteriorly. I know that it has been a long time, but we discussed once the P wave, how is it constructed by the right atrial depolarization and then the left atrial depolarization, and the net forces are down and leftward for the frontal plane, and for the horizontal plane it's going to be anteriorly and leftward. So if you try to see it in your frontal leads, then the P wave axis is going to be plus 40 to plus 60. And anything less than 40 or more than 70 is going to be left axis or right axis deviation for the P waves. Usually, if there is a congenital heart disease, the axis is either more than minus 30 or less than plus 70 degrees. If it is nodal rhythm, then it's going to be a superior axis. If it's going to be low atrial pacemaker, it's going to be a superior axis. That means the axis is going to be less than 0 degrees. That means negative P wave axis. And if I have my atrial situs, which is inversus, then my P wave is going to be downward and rightward. That means it's going to be around plus 120 degrees. If my P wave axis is plus 120 degrees, I need to make sure that it's true atrial situs inversus in a mirror image dextrocardia, and not that I have reversed the arm electrodes. How do I decide that? I will also see my Qrs axis. If my Qrs axis is also reversed in the precordial leads, then it's going to be likely a mirror image dextrocardia. So the message is normal P wave axis is plus 40 to plus 60. As you understood, the normal Qrs is also from plus 40 to plus 60. Now, coming to the T wave axis. So as we know, the T wave axis is decided based on the vectors of ventricular repolarization, and normally it ranges from 0 to 90 degrees. However, it's going to be different for different age groups because there is going to be right ventricular hypertrophy in a newborn. So, the T wave is normally upright in V1 in the first 3 days of life. After that it becomes negative from the 4th day of life, and it stays negative for a couple of years, which is usually 3, 4, 5 years. And after that, it again becomes positive. So any T wave which remains negative after the age of 8 years is considered abnormal. Till 8, you will accept it to be the normal transition phase. The T wave axis can become abnormal in situations where we have repolarization issues. That means if I have myocarditis, pericarditis, ischemia, or conduction disturbances, bundle branch block, or ventricular hypertrophy, then my T wave axis is going to change. Remember this message, the T wave axis moves away from the region of pathology. That means if I have myocardial ischemia, the area where ischemia is there, the T wave axis will move away from that region. So if I try to decide my T wave axis, I can decide that exactly opposite area is going to be involved in the pathology. So this is the role of T wave axis determination. The Qrst angle is also important. So what is Qrst angle? You first decide the Qrs axis, then you decide the T wave axis, and the angle which is formed between the two axes is the Qrst angle. You know that the normal Qrs axis is 40 to 60 degrees, and the normal T wave axis is also 0 to 90 degrees. So the Qrst angle normally do not exceed 60 degrees. And this is an important concept because it relates the ventricular depolarization to ventricular repolarization. What if my Qrst angle is wide? If it is wide, then it is not considered to be normal after 3 months of age. But remember that my original T wave axis importance is much more than the Qrst angle. So my Y Qrst angle is less significant if my T axis is normal compared to when my T axis is abnormal. And you can see that your Qrst angle is going to be wider than 60 degrees in situations where you have a strain on the ventricle. For example, aortic stenosis, or you have myocardial dysfunction. Then your Qrst angle is going to be wide. Now there is a concept of ST segment axis also, and you do the calculation in a similar way. Your ST segment is directed towards the surface of injury. The T wave axis goes away from injury and your ST segment axis goes towards the injury. For example, if you have pericarditis, and normally you have pericarditis near the apex to start with, then your ST segment will be like 30 degrees. So this is the importance of understanding the ST segment axis. Remember that in situations where you are diagnosing ventricular dysfunction, ischemia, pericarditis, myocarditis, there comes the role of T axis, the Qrst angle, and the ST segment axis. I hope so far whatever we have discussed is clear. And now we are going to see another aspect of axis determination. So far what we were talking was in the frontal plane. The determination was happening in the hex axial system. Now what about the horizontal system? Because this does not give us an understanding. The frontal plane does not give us an understanding about the anterior-posterior relationships. It just gives us an understanding about superior, inferior, right and left. So what about the intero-posterior? Is there something like an intero-posterior axis? Yes. And for that anteroposterior understanding, we need the horizontal system also. And how do we understand the horizontal system? The principles are exactly similar. This is just a recap of what we had done in the first class. This is the vertebral column, this is the sternum, and this is the heart. So this is an axial cut of the chest. And in the horizontal system, we have the leads starting from V1 to V6. And all of you know that V1 is put on the right parasternal area and V6 comes closer to the mid-axillary line. So all your leads are in this area. Overall, the horizontal system is not as precise as the frontal system, and hence commonly we pay attention to the frontal system. But having to complete an understanding about the axis of the heart, we will also understand a little about the horizontal system. So here you can see that the angle between the lead V2 and V6 is 90 degrees. And approximately between the two leads is going to be a little less than 30 degrees. So if we consider like how we took lead 1 and AVF which are perpendicular to each other, in the horizontal system we will take the lead V2 and lead V6 as perpendicular to each other. So if I consider lead V2, this is positive for V2, this is negative for V2. If I take lead V6, this is positive for lead V6 and this is negative for lead V6. Now let us see in the subsequent figure. Lead V2, you can all see the middle figure. Lead V2, the front half of the semicircle decides the positive polarity and the back half of the semicircle decides the negative polarity. In the last figure, the left half is the positive polarity for lead V6 and the right half is the negative polarity for lead V6. Similarly, if you try to understand V1, V1 is a little towards the right side, then this is positive and this is negative. So we will take help of similarly lead V2 and V6 to decide whether our Qrs axis is more anterior, more posterior or intermediate. So now if you take care of your lead V2 and if your lead V2 is dominantly positive, then your QRS vector is more anterior. If your QRS vector is more negative in lead V2, then it's going to be more posterior. And if it's equiphasic, then we will term it as intermediate. And this principle, you can use it for the P wave and the T waves also in the horizontal system. So you check your leads from V1 to V6, pay most attention to lead V2. You can also add V6. If in lead V2, either QRST or P is positive, then it's an anterior axis. Negative, then it's posterior axis. If it's equiphasic, then it's indeterminate. Now, this is sort of a summary of today's session to just understand how axis changes from newborn period to adulthood. So in a newborn, the QRS axis up to 180 degrees is considered to be normal, and then in an adult it's usually up to plus 90 degrees. The transition happens somewhere around 3 years of age, but it could extend up to 8 years of age even in a normal heart. If you try to understand the Qrs complex, the R wave is positive in the right precordial leads in a newborn, and it's still not considered to be abnormal. But if you have pure R with no S in lead V1, and if it's more than 10 millimeters in a newborn, please understand that it is abnormal and it suggests RVH and we need further evaluation. So what is the way to find out if you have RVH in spite of having physiological RVH in a newborn? If you have pure R more than 10 millimeters in V1, it is abnormal. And then as time goes, you have dominant R in left precordial leads, which is V5, V6. Similarly, S wave is more negative in left precordial leads in a newborn and more positive in right precordial leads in an adult. The RS progression is reverse of an adult. That means R is more dominant than S in right precordial leads, whereas is more dominant in left precordial leads in an adult. So that's where the RS ratio comes into picture. T wave is also very important. You have T wave which is upright on day 1 in V1, and then after day 3 it becomes negative, and then it becomes again upright by 8 years of age. And another way to find out the right ventricular hypertrophy in a newborn is a QR pattern in V1. So if you have a small Q and a dominant R with no S, that means you have RVH in a newborn. So I think this is the end of our session today. This is about axis determination. You all know what we did in the previous session, which includes the basic understanding about how an ECG is done, the individual waves and the segments and the intervals. Any questions, please feel free to ask. We are going to have a quiz next month in September, and I am sure all of you are interested into understanding, what all we gathered in the last 3 sessions of the basics of ECG. You can go through whatever videos we have uploaded so that you are going to have a revision of whatever previous lectures and go through it so that we are all ready and excited for the September quiz. Feel free to ask any questions for today's session. Hello? Amrita, are you still there? Can you hear me, Amrita?
Ma'am.
Okay, fine. If anybody has any questions?
Any questions?
Ma'am, I think there is no questions.
No questions. Hope everybody was there. It was not
Yeah.
only talking, no?
Yeah.
Okay. No questions. Thank you very much.
Yeah. Thank you, ma'am.
See you next month. Thank
Yeah.
you.
Thank
Have a
you.
good day. Bye.